So glad that you are here to join us for our little webinar where we're going to visit together about some orthodontic principles for the next 60 to 90 minutes or so. So grateful that you're here, that you joined us. I am excited and passionate about orthodontics as a general dentist and excited to talk to you about it. So really grateful you're here. Really grateful for the American Dental Association, the ADA, and for Progressive Orthodontic Seminars for giving us this opportunity to be together tonight. I do have a support team from Progressive Orthodontic Seminars on with us. Yassine and Yvette and Gabby, part of our support staff and directors, and they'll be available to help with questions at the end of our webinar tonight. We will try to leave some time for questions. So as we move along, if you have questions, feel free to type them into the question and answer box. And at the end, I will go back and try to answer as many of those as I can. So let me just tell you a little bit about myself. This is my pride and joy here is my family. And you can see here my wife of 27 years today, actually. That's our 27-year anniversary. We're going to dinner and when we finish up here. And we have 4 boys, you can see in the picture. And we have 2 daughter-in-laws. I always wanted daughters and didn't get any by birth, but have 2 awesome daughter-in-laws who have joined the family. So we are excited about our growing family. I had a general dental practice in San Clemente, California for almost 20 years. And probably one of the best dental teams in the world, in my view. Love these ladies. They are like my family. And I was interested in orthodontics in 2008 when we had a recession and all of the cosmetic work in Southern California and probably throughout the nation, many of you may remember, started to dry up. And I was looking for other sources of revenue and just had a general interest in it. And so I started training. It was a 2-year training program for me with Progressive Orthodontic Seminars. I'd heard wonderful things about them and how comprehensive their training was. And so I started training with them and started providing orthodontic services in my practice, both braces and aligners. And honestly, it was one of the best things I ever did in my general practice. In 2017, I had a surprise and started having some functional problems with my hands. Started losing some fine motor skills in my hands and found out that I had cervical spinal stenosis. It was severe, a bone spur growing into my spinal canal down at C5 and C6, and found out that I had to have that surgically removed and that the damage done to my spinal cord was irreversible and I wasn't going to get that function back in my hands. And that the other levels in my neck were pretty bad. And that if I went back to hanging over my patients doing dentistry, I would probably end up doing multiple levels in a few more years. And made the difficult decision to sell my clinical practice and retire clinically from dentistry. And fortunately, having trained with Progressive Orthodontic Seminars and having done ortho in my practice for about 10 years, I was given the opportunity and have the pleasure of being one of the instructors for Progressive Orthodontic Seminars and traveling worldwide to teach doctors about orthodontics, general dentists who want to do orthodontics in their practice. And we have 2 series that are taught. One is the traditional orthodontic series, which is literally 2 years. It's 12 different weekends. So we go every other month for a full 4 days. And by the end of this series, you basically know what the specialists know. And that's the goal of Progressive Orthodontic Seminars, is to be able to do orthodontics at the level of the specialty. They also have an aligner focused series for doctors who don't want to do as much with braces and traditional orthodontics, but really would just like to do a great job of providing aligner treatment in their practice. And that's 4 different weekends, 3 days each weekend that we provide that. We'll talk more about that at the end of the webinar, but that's what I do. I love it. I'm passionate about it. I enjoy teaching. And that leads me to opportunities to do consulting and mentoring with individual doctors so that they have confidence going into their cases as they learn. It's a great thing about orthodontics is any other thing that we do in dentistry, any other service that we provide, we have to be proficient and know how to provide that from start to finish. Whereas with orthodontics, it's something that we start and we finish 12 to 24 months later. And so we can start cases and actually learn the orthodontics as we go and as we treat those cases. And that's actually the best way to learn, because we learn better while we're doing. And so doctors are able to come in and start cases right away. And that's kind of what we're going to talk about today, is some of the cases that if you were to start your orthodontic education, you'd be able to jump in and start treating these kinds of cases this year. Some of you may already be. So I want to know a little bit more about you. So I'm going to put up some poll questions here. If you can take just about 30 seconds and answer, let me know what your level of experience is. I have brand new to orthodontics, never done an ortho case, limited experience. Maybe you've done some simple aligner cases, or maybe some simple traditional braces cases, somewhere between 1 and 30 completed cases. Moderate experience, you've done traditional braces or aligner cases, but you've done more of them, maybe between 30 to 100 cases. Or there may be some with us tonight who have extensive experience, have done more than 100 completed cases with braces or aligners. So if you can answer that question real quick, I'd love to know who's in our audience, and I'll click onto the next page and see your responses. So it looks like about 40% of you are brand new. That's awesome. This is just for you tonight. And then another 33% are limited experience, maybe have dabbled in it a little bit. You've done enough to know that you need to know more. You've done enough to know that you can get yourself into trouble. And then it looks like we got about another 25% who have done either 30 to 100 or even 100 or more. So awesome to have a little bit of a diverse group. Glad to have all of you. Those of you who have more experience, hopefully you hear something in this short hour that we have. Obviously, we're not going to be comprehensive, but hopefully I can touch on some things that may be helpful for you as well. Those of you who are brand new, my goal really is to just whet your appetite, to help you see a little bit of what's possible and realize that you can do this in your practice. It's really fun to learn orthodontics from a general dentist when you're a general dentist, because we're not trying to teach you how to refer. We're trying to teach you how to do these cases proficiently, how to treat at the level of specialty in your own practice. So I found that, as I said, that offering orthodontic services in my practice is the best thing I've ever done in my practice, apart from deciding to be a dentist. So I've highlighted a couple of things here I just want to mention. One is just the joy of orthodontics. When I started providing orthodontic services in my practice, it just was fun. And you may have certain services that you provide that you get excited when you see it on the schedule because you like it. It's fun. It brings great energy into your practice. Like when you do awesome cosmetic work, it's really fun. Yes, you get paid, you produce, but it's fun. You feel good. You've changed somebody's life. They go out and smile and feel different about themselves. And orthodontics just brings that excitement into the practice, both for you and your staff and your patients. I like to treat younger patients as well. And there's not a lot of things that we have to offer in our practices for younger patients, except maybe the toy box that they get excited about. And when all of a sudden you're doing orthodontics, you're able to provide cosmetic services for younger patients. When they feel unhappy about their smile, when they are bullied, or they just don't feel confident, and all of a sudden you get to do something that changes the way they feel about themselves, the way they carry themselves, the way they present themselves. That is really fun. I love it. I think that it makes you a better practitioner. I know it makes you a better practitioner. I said here, orthodontic lens. Nothing helped me understand dentistry better than doing orthodontics, realizing that teeth move, why teeth move, how they move. When you start to see your patient and the whole mouth through an orthodontic lens with an orthodontic education, you just understand the mouth better, how everything works. And I just feel like you're a much better clinician. It definitely helps to recession-proof your practice. And as I said, that was one of the reasons why I decided to go into orthodontics. Just making sure I can use my little drawing tool here. Here we go. Recession-proof the practice. When you do orthodontics, one, you have parents who, even though they may not be willing to spend money on cosmetics and other things, everybody plans on paying for braces for their kids. It's almost something that they already have saved up and they just know they're going to have to do. So it really does help you get through some tight times, which I think we're coming up on right now. So this is a great time to jump in and learn some orthodontics. Also, the payments get spread out, so instead of doing the service, getting paid for the service, your service in orthodontics takes 12 to 24 months. So you're receiving payments every month, and those payments help to just smooth out the collections. And so that's a big point for me. Getting referrals, it's another source for referrals. I found that I got referrals from kids, and before during ortho, I really wasn't getting many referrals from kids. But when all of a sudden you have 12-year-old Susie in braces and she's telling her friend about it, and now you get the friend's whole family as new patients because this 12-year-old is out there talking about you because they have their braces and all that stuff. That's a kind of exciting and fun. And I also found that I got more referral from specialists, local oral surgeons, local periodontists, local endodontists, as I started doing orthodontics in my practice, because they could tell that the level of understanding and care that I was providing was elevated above other practices in the area. Another huge plus for doing orthodontics in your practice is doing more cosmetic treatment. Whenever we start talking about straight teeth, it always leads into conversations about cosmetics for the whole mouth. And straightening people's teeth leads to more cosmetic treatment. And I love doing cosmetic treatment. And so for me, providing orthodontic services really increased the amount of aesthetic treatment I was able to do in my practice. It's awesome for improving periodontal problems, straight teeth that aren't crowded, that give room for the gums and the bone in between the teeth when the roots are aligned properly, just leads to better periodontic health. Better TMJ function helps us to be able to do our own setups for implants. Hopefully some of you are doing your own implants, or at least the simple ones, and not having to refer to an orthodontist in order to prepare for an implant before you place that implant, getting the site prepared, getting the teeth that have maybe tipped into that site aligned properly, or just any preparation that we need to do for overall prosthetic work. It is just fun to be able to provide orthodontics in our practices. I love it. So ask yourself in your practice, how many ortho cases are you referring out each month? When we hit that point where I could tell we were going into recession and I wanted to increase the revenue in my practice, I looked at each of the different things I was referring out: wisdom teeth removals, oral surgery, endodontics, pediatrics, and ortho. And for sure, I was referring out more ortho than anything else in my practice. And not only that, since I didn't know ortho, I was not recognizing all of the orthodontic cases. So even though I was referring a lot of cases, there were a lot more cases that were just not even being talked about because I didn't recognize them as opportunities. So when I added up the number of referrals I was sending out, plus the cases I wasn't recognizing, there was a lot of unrealized or lost production in my practice. So as we go through this and we start talking about orthodontics, if you're like, hey, I love this, this is great, maybe it's time to increase your education in orthodontics so that you can do more of this and increase your revenue. So a question for you. What is your motivation? What would be your greatest reason right now to increase your education, knowledge, skills in orthodontics? If you guys can all just take 10, 15 seconds to read through these questions. Increase your revenue to the practice, expand your knowledge and skills, become a better clinician, bring new energy and life into your practice, keep things exciting and new, create a new source of referrals and grow the practice, create a higher demand in your practice for cosmetic or comprehensive treatment. What would most drive you to get educated and offer orthodontic services in your practice or increase the amount that you're doing? We'll give you another few seconds here. I love it. Looks like the majority of you are motivated by wanting to increase your knowledge and skills and just be a better clinician. I think that is a wonderful reason to go into orthodontics. And all of these other reasons are definitely there. It's definitely a reason to do it. And I like too that there's a lot of interest here in creating new energy in your practice, doing something new. It makes your career more exciting. and creating higher demand in your practice for cosmetic work and overall comprehensive treatment. I love that. Thank you. So here's the topics that we're going to cover briefly tonight. I wish we had time to go into all of these topics. I love these topics. You know, if you come to our courses, we will have days to talk about these together and really dive in and really master these things together. We're just going to be able to touch briefly on these different topics tonight, but if you do have questions, feel free to type them in and I'll try to address them at the end. So we're going to discuss pseudo classes, specifically a pseudo class 3 type case that you could start treating this year if you sign up for courses and start learning, or maybe you are already doing ortho and just need to recognize these as being easy, predictable, great cases to treat. We're going to talk a little bit about non-extraction techniques using expansion, expanding arches to treat crowding. We're going to talk a little bit about diagnosing young patients. Okay, for me, this was one of the biggest reasons that I went into my education. I'll talk more about that later. But when parents would ask me, hey, does my son or daughter need braces? I really didn't know what to say. I could tell if there was a major problem, but I really didn't know what I was looking for. And that was one area, you know, 5 or 6 years into my practice, I was like, I am really lacking. They didn't teach me anything in dental school about orthodontics. So I don't even really know what I'm looking at. I don't know how to talk intelligently to the parents about when they should go see the orthodontist, what might be going on. So we're going to talk about that a little bit. I love that topic. We're going to talk a little bit about treating high or impacted canines and about some ways that we can treat open bites. So let's jump in. Okay, the first thing we see here is we're going to talk about pseudo classes, and specifically pseudo class 3. That would be a case that looks like a class 3 case, but it's kind of a fake class 3 case. Or it's not a really strong class 3. It's very mild, but the patient is doing mandibular posturing, meaning they're functioning with their mandible being held in a more forward position in order to get their teeth to fit together. And so the case will look more class 3, but actually it's not that challenging. It's not that difficult to treat. So here we have this patient. Incidentally, the photos that I'm going to be using are coming from the course material for both the traditional orthodontics and for the aligner courses. And so this is where I'm pulling these cases and these photos from. So here we have a patient. She appears to be in her late 20s or early 30s, and her chief complaint is crowding of her front teeth and her facial appearance. And if you look at her face, you can see that her mandible does look strong. It looks more protrusive than the upper part of her face and her maxilla. She may be a little bit deficient in her maxilla, but she has kind of a nice curvature here. And so she doesn't look real deficient in her maxilla. It just looks like her mandible's a little bit strong. So let's look in her mouth and see what's going on. Obviously, she's got some crowding in the front, and she's got a crossbite in the front. If we look at the occlusion of the back teeth, and we look at the position of the upper canine, okay, this upper canine is fitting pretty nicely right in between the lower canine and the lower first bicuspid, which is exactly where it belongs to be considered a class 1 position. And over on the left side, that canine also drops nicely right in between the lower canine and the lower bicuspid. So we have, it might be just a little 0.5 millimeter or so class 3 on that left side. So actually we're dealing with a pretty straightforward class 1 occlusion on the back, which, you know, that's makes for sometimes a pretty straightforward case to treat. Okay. But because of the anterior crossbite, if she were to bite together with her jaw not being pushed or held forward, she would hit the edges of her front teeth, which is not comfortable for patients. And so as these teeth were erupting, and she found that if she was, you know, when she was younger, that if she bites down, she hits the edges of her front teeth, and she can't move her lower jaw back any further in order to avoid that collision in the front. So what she does is she starts to just posture her lower jaw, her mandible slightly forward to get in front of those upper teeth so that there's not a collision. And then all of the adult teeth end up erupting into this pattern, into this position. Okay. The way that we are able to identify this, so whenever we see a anterior crossbite in a patient that we're considering doing orthodontics on, we always ask this question. We say, can you bite on the edges of your front teeth? Okay, and a true strong class 3 case, they're not going to be able to bite on the edges of the front teeth. So they can try to pull their mandible back, but they're not going to be able to get to where they're biting on the edges of the front teeth. They're always going to kind of have that anterior crossbite. Okay, whereas a patient who has a pseudo class 3 position where they're posturing or functionally shifting their mandible forward, they're going to be biting right on the edges of their front teeth, and then they're going to have a posterior open bite. And that posterior open bite is because they're hitting those front teeth. Those teeth had erupted into a position where they're fully in occlusion when the patient shifts their jaw forward. So if you look at this picture on the bottom, and you consider that the crossbite in the front is really not as difficult to correct because those teeth are edge to edge. Those upper teeth just need to be moved forward a little bit, and the lower teeth need to be moved back a little bit. And then we're going to clear that collision in the front, and the patient will be able to now bite with their mandible in a whole new position. Okay, so this particular case was treated with braces, but this can also be done with aligners. I'll show you the result here, and then we'll go back to that list. So this is what her case treated out as with braces. Okay, so you can see that she has a closed bite in the back. She didn't finish with an open bite in the back, but she was able to get the correction done in the front. And we'll see when we look at her face photos of the finish that she doesn't look as class 3. She's not having to hold her mandible forward anymore. Okay, and all that was required in this case was putting on braces and aligning these teeth. It really wasn't a difficult case to align the teeth. The upper teeth have crowding. They're going to advance forward. The lower teeth have some crowding, but the canines were in class 1 position. So as everything straightens, you know, we might have to do a little bit of IPR, a little bit of tooth reduction in the lower, or we might have to use a little bit of class 3 elastics, okay, where we would put elastics from the upper first molars to the lower canines to pull the upper front or the upper teeth forward just a little bit. But this is real mild correction. Besides just alignment, it didn't take a lot of correction of the posterior occlusion. So these can be pretty straightforward cases. If we're doing aligners, what I like to do is I like to take records. So take your scan, your bite registration or your scan of the bite in this position where the patient is biting on their front teeth. And I send it to the aligner company like this, and I ask them to mount it in this position that has them biting edge to edge and doesn't have them with a posterior occlusion. They're open in the back. And the technician, the aligner company, will want to extrude the posterior teeth to make the bite come together, but you don't want them to do that. All you want them to do is leave those back teeth alone, leave that open bite in the back, and have them focus initially on the front teeth. So they're going to advance those upper front teeth to get rid of the crowding. They're going to line the lower teeth, maybe do a little bit of IPR to pull those back until we get rid of this anterior collision, which isn't going to take a lot of work. It's going to be fairly easy to get rid of that anterior collision. And when the patient has the aligners out of their mouth, you just check when they come in. If they've cleared that and they can now get their bite together, once I've cleared the anterior collision and we can now get the back teeth to come together, they're not going to fit quite as perfectly as they did here, but they're going to come together a lot more than they are here. I'm going to do a revision. I'm going to take a new scan or new records, new impression, and a new bite and send it to the aligner company for new revision aligners that now are addressing the new bite, okay? The bite where the patient is no longer holding their mandible forward. And we're going to move from that point on to, you know, coordinating the arches, getting the teeth all aligned, but it's not going to take a lot, okay? It's going to be pretty close once you get this anterior collision resolved. So these can be really rewarding cases because the patient's face ends up looking much better and the teeth look much better, but it really wasn't that difficult of a case, not like a true class 3 case. So here's a quick list for you and a picture of a pseudo class 3 case compared to a true class 3 case. Okay, in a pseudo class 3 case, the jaw sizes tend to be normal, upper and lower. okay, in both dimensions, both transverse dimensions and in anterior posterior dimensions. In a true class 3 case, the mandible is just going to be larger in every dimension. It'll be wider in the transverse dimension than the upper, and it will be longer in the anterior posterior dimension than the upper. So we really do have an imbalance in the size of the jaws, upper and lower. In the pseudo case, the upper incisors tend to be tipped back, retroclined, or tipped lingually, which is great because we want to tip them facially in order to fix the crowding and get them out of that crossbite. Okay, so they start a little bit tipped back. And the lower incisors are typically in a normal or even slightly proclined or facially flared position, which is great because we want to move them back. Okay, with a true class 3 case though, where the bones don't line up properly, the mandible is too far forward and the maxilla is too far back, the upper incisors tend to start out flared. They're already proclined. So moving them forward is more difficult because it doesn't look as good to flare them even more to get rid of that and that crossbite in the front. And the lower incisors tend to already be tipped back. Because of this patient's bone imbalance, they already have what we call dental camouflage or masking, where the teeth have naturally tipped forward in the upper and tipped back in the lower to try to get rid of the difference between the upper and lower teeth as far as their position. So you're starting with teeth that already are in a poor position in these true class 3 cases. In the pseudo cases, the patient can bite on the edges of their front teeth if we ask them. So we always ask them, can you bite on the edges of your front teeth? And if so, we're going to take our records in that position. True class 3 patients, the patient cannot bite on the edges of their front teeth. The way they're biting with that anterior crossbite is truly their bite. They can't shift their jaw back and bite differently. With a pseudo class 3 case, the lower canines tend to have normal positioning. The crowns are in a normal upright position. Whereas with a true class 3 case, the lower canines tend to have the crowns tipped to the distal. You kind of see it in this picture. Those canines are tipped distally. So that's another giveaway that it's a more challenging class 3 case. Okay, the pseudo class 3 cases tend to just have an anterior crossbite. So not really a problem in the posterior occlusion. There's no posterior crossbite. Whereas with a true class 3 case, you have anterior crossbite and you have posterior crossbite. Maybe on one side only, maybe on both sides, but you can see that there's more than just an anterior crossbite. And lastly, the posterior occlusion in a pseudo case is going to be close to a class 1 occlusion with the canine in the proper position, like we saw in this case. Whereas with a true class 3 case, they're going to have more dental class 3. And so that upper canine is going to be, several millimeters or more behind that position where it should be dropping in, between the lower canine and lower bicuspid. So those are some ways to tell. The real giveaway for me is when you ask the patient to bite on the edges of their front teeth. Okay, so when you see cases, you're like, well, I don't know, maybe I could anterior crossbite, maybe I could treat this, maybe it's going to be a really hard case that I should refer out until I have more education. And that's what we're looking for. Okay, it's a good, helpful little list there. Okay, so here's how that case treated out. You can see that the canine finishes class 1, drops right into that spot between the lower canine and lower bicuspid. It's pretty unchanged from the start. Her posterior occlusion didn't really change. Teeth got straighter, but the occlusion didn't really change. But the lower teeth tipped back a little bit, the uppers flared out a little bit, and she no longer pushes her lower jaw forward. So we're going to see a difference in the way her face looks. And there you go, start to finish. Okay, you can see a change, and we'll show you a close-up here in just a second, but you can see a change to the way that her overall facial profile looks. Her balance is much better, and she's going to be real happy with that. Okay, there you go. So it almost looks like a surgical correction, almost looks like she had a mandibular setback or an advancement of the maxilla because of the change to her overall profile. And all it was here she's holding that mandible in a more forward position to get her teeth together because she doesn't want to hit the edges of her front teeth. And once we get rid of that collision in the front, she's able to shift her jaw into a more comfortable position, actually a better position for that TMJ, for that temporomandibular joint. So those are great cases. Those are great cases to treat. Now let's move on to the next topic here. Non-extraction treatment using expansion, okay? You can do expansion with aligners and with braces, okay? When we do braces, we use wires that are more expanded than the original arch form. When the patients are younger, they respond better to that because their bone is more malleable. It's still growing. It can change more. When we get into older patients, more adult patients whose teeth have been like that for a long time, they can be a little bit more resistant because the bone doesn't want to change and expand quite as much. I'm not talking here about the kind of expansion that would be involved with somebody who has a crossbite. Okay, sometimes true crossbites require more than just moving teeth. Dental alveolar movement, it requires completely expanding the maxilla, which on younger patients, we'll talk about later, can be done with rapid palatal expanders, where we actually open up that mid-palatal suture and move those bones apart from each other and make their maxilla wider. And we're not talking about that right now. So when we're talking about expanding arch techniques, we're talking more about like arch form development, okay? Making the arch forms wider in order to treat the crowding and not having to extract teeth, okay? When we teach our seminars, we have whole courses on extractions because there are times when extractions are indicated. We can't just expand the heck out of everybody and make all their teeth fit. There are times where extractions are necessary. Okay, but we're talking about here non-growing patients who just need some arch form development, okay, to make things a little bit wider, to make their smile more attractive and to get rid of some crowding. So as you look at this young man who's late teens, he has fairly large buccal corridors. Okay, so it's hard to see in this picture, but where his teeth are in the maxilla leave a large gap, kind of a large dark area in those buccal corridors. Okay, so it would be nice, when we look in his mouth, it'd be nice to find out that we could expand those upper bicuspids out and give him a little bit more full smile. So let's look in his mouth, see what's going on. There are some red flags in this case. We're not going to go into this case completely in the interest of time, but if we look at his midline, okay, upper midline, hang on. Look at his upper midline compared to his lower midline, you can see that his lower midline is actually off significantly from the upper. Okay, if I'm starting out in orthodontics, I need to understand where that's coming from. And that's a topic for a whole day's worth of conversation. So we're not going to go into that, but just in case you're looking at this going, oh, everything in this case looks really easy. I'm not showing you the posterior occlusion, okay, because there is some asymmetry in this case, and asymmetry can be challenging. But what I want to show you in this case is this idea of handling the crowding by doing some expansion or some development of the arch form. Okay, so this young man has a little bit of an omega shape to his posterior arch form. Okay, those bicuspids are tucked in a little bit. So when I look at his smile, I can't see the bicuspids. They're kind of hiding behind the canines. I don't see them as much as I would like to be able to see them. And he does have some crowding in the upper, maybe 3 millimeters or so, maybe a little bit more of crowding in the upper. In the lower arch, he also has crowding, more than in the upper. And you can see here in this picture, you can get an idea that there's a little bit of excess overjet, okay? So a little bit more crowd in the lower is not a bad thing, because as I move these teeth forward to fix the crowding, it's gonna reduce this overjet that he has here and help us get a nice result. Okay, but in the lower, he's probably got more like 5, maybe even up to 6 millimeters of crowding in the lower. Okay, so as I look at that, I think, well, this is great. He would look better if I were to expand his bicuspids out, maybe the first molars a little bit, so that I can resolve the crowding in the upper without really moving the position of incisors. I can leave the incisors in the start position. And in the lower, then, that will give me room to move these bicuspids out, maybe the first molars a little bit, and that's going to help me resolve some of this crowding without having to move the teeth forward. But since I have more crowd in the lower, I'm also going to have to move the lower teeth forward, which will help me with the overjet problem. Okay, and if we're going to do aligners, we get to go and submit it to the aligner company and actually see the technician make these movements, so that on a 3D model, before we ever start, we can see how much expansion we can start doing before we, really change the position of those front teeth. Because I don't want to pull this patient's front teeth back. If you look at his face, he's got nice facial balance, okay? In fact, he might even be a little bit concave in his facial profile. So I don't want to retract his teeth and make his lips come back because he looks good the way he is. I don't want to pull his lips back. They're not sticking out too far. Okay, so I want to end with his upper incisors near their start position, but I can get rid of the crowding in the upper by expanding him out. And aligners do a really good job of this because aligners push against the teeth. So as I have aligner material covering the lingual surfaces of these teeth, they can push in a buccal direction, and it's pretty predictable to get up to 2 millimeters of expansion per side. Okay, and I'm assuming that there's no recession on these bicuspids that's going to cause a problem if I push them out to the buccal. Okay, so this one was treated with aligners, and if you look start to finish, it's a nice looking case. Some of the challenges that we're not going to go into on this case were resolve some of the asymmetry. Got a nice alignment of the upper and lower midlines. Okay, there was a bit of a deep bite, and you can see the deep bite was corrected. But what I want to focus on here is look at the development of the arch form. Okay, look at this nice rounded out arch form that the aligners were able to accomplish. Okay, compared to this kind of omega shaped arch form that was kind of pinched or compressed through the bicuspids, making his smile look like those bicuspids are kind of hiding back here. And in the final position, those bicuspids, they're in a position where they can reflect some light back at you. So when the patient smiles, you see those teeth back there. And when you look at the lower arch, you can also get a sense of this kind of omega shape that's been expanded or developed into this nice round arch form and got rid of that crowding in the front. Okay, so aligners do a really nice job, even on non-growing patients, up to 2 millimeters per side of expanding, rounding out an arch form to get rid of the crowding, so non-extraction, and make for a really nice result. And as you look at his smile, from the start where he had these large buccal corridors to the finish where his smile looks more broad, you can see those posterior teeth more. Sorry, I'm having problems with my pen here. It's hard to draw with a mouse, especially when you have a little bit of nerve damage in your hands. But you can see this nice broad smile. And we didn't change his profile, okay? He still has nice balance. We didn't pull those teeth back and retract his lips back. Let's look at one more case like that. Okay, here's a gal who complains about crowding. She looks to be in her early 30s. And again, when you look at her smile, it looks like these bicuspids are kind of tipped to the lingual. They're kind of hiding behind those canines, and the canines are maybe a little bit flared even. And so that gives her these larger buccal corridors. It'd be nice to see more of her posterior teeth, more of those upper bicuspids when she smiles. Just like the last young man, she has nice facial balance. Okay, she's pretty straight in her profile. Her lips are nice and full, but they're not excessive. I don't need to retract. I wouldn't want to retract her teeth back. I would like to finish straightening her teeth and leaving her lips right where they are because they look really nice. So let's look in the mouth and see what's going on. Okay, so you look in the mouth and you see crowding in the upper arch, but you also see this tapered look in the front, and again, this omega shape of the posterior teeth. And in the lower, you can see this real tapered shape to the arch. So this would be another case where, this isn't a case that needs like rapid palatal expansion. It just would be nice to develop an arch form that's a little bit more rounded out so that we can see her back teeth better. Okay, and where we can round out this lower little bit to get rid of the crowding. She doesn't have a crazy amount of crowding. Okay, she's got a little bit more in the upper than in the lower, but it's not the kind of crowding where we have to extract teeth. So if we were to do braces, we could use an arch wire that was more rounded through these bicuspids to try to help pull those bicuspids out. and give her that broader smile, or we could use aligners and use the aligners to push those teeth from the lingual out towards the buccal. Okay. Here's what she looked like. And not a difficult case. This was probably about a year's worth of treatment. I would have quoted her 12 to 18 months to give myself 6 months of wiggle room to get the case done nicely. But look at how now when she smiles, I can see those posterior teeth. They reflect light back at me and it fills out her smile. Okay. Little bit limited. It looks better on her right side. We were a little bit limited on what could be done on the left side because this is a bridge right here. Okay. There's 3 teeth that are splinted together because of a missing molar. And so we really were not able to move these teeth out. So we had to limit how much we could move these teeth out. So there are factors in every case that will determine what we can and can't do, and we have to work around that. So you can see that the left side didn't get quite the correction that the right side got as far as filling out that smile, but we were limited by existing conditions. Okay, but look at this arch form change. So when you look at the arch form in the upper, that omega shape that we talked about, compared to the final one, again, that upper right side looks a little bit better than what we were able to do on the upper left side because of the bridge on the left side that dictated that position and said, we can't move these out, so we're gonna have to limit how much we move these out. But you can see how aligners are used to change the arch form. Now, this isn't true, maxillary expansion. We didn't take this maxillary suture and open it up and expand the bones apart from each other. All we did was dental alveolar movement. We're moving the teeth within the bones, within the envelope that the bone already provides. And, even adults can have some bone remodeling. So up to 2 millimeters per side is pretty predictable. Okay. So expansion. Question for you. How do you feel, how confident are you in discussing with a patient or the parent whether or not their young patient, their child needs orthodontic treatment? So kind of back to that comment I made earlier. That was one of the reasons why I wanted to pursue orthodontic education was I didn't feel very intelligent when I'm doing a hygiene exam on an 8-year-old and the mom says, do they need braces? And I was like, I don't know. I don't know what I'm looking at. So for me, I would have said strongly disagree or maybe agree, one of those two. So where are you guys at? I'll give you 10 seconds or so to answer. All right, so 37% of you strongly agree with that statement. 33% agree, 11% neutral, and about 18% disagree. Awesome, so let's get into discussing a little bit about young patients. When we teach the aligner courses, that aligner course is not a phase 1, phase 2. We don't teach phase 1. The comprehensive series that we teach, the 12 seminar series that teaches traditional ortho, is where we go into all of these things that we use to diagnose and treat young patients that are in mixed dentition who still have primary teeth. Okay, so we're going to touch upon some of the things in young patients and mixed dentition treatment plans. I find it fascinating because it really impacts how these children grow and how they develop. I love thinking and talking about, the way the face develops because of the occlusion and how the way that they function changes the way their face grows and how their teeth grow, how their bone develops. It's a fascinating topic for me. The things that we look for, basically, we're looking at 3 dimensions of space, okay, when we look at a child. And usually somewhere between 7 and 9 years old is where we really want to have a close look. As those anterior incisors are coming in, the permanent incisors are coming in, as the upper and lower 6-year molars, the first molars are coming in, we can really see some patterns being established that allow us to get in there and have a look and decide whether it's time to give the referral or time to take some ortho records and start treatment in our practices. So we're looking in the transverse dimension, we're looking in the anterior posterior dimension, and we're looking in the vertical dimension. So we have 3 planes of space that we're looking in, okay? So the vertical dimension would be open bites or deep bites, okay? The transverse dimension would be the posterior cross bites, and the anterior posterior dimension would be our occlusion of class 2 or class 3. So let's just touch on these topics a little bit. Okay, the first thing that we want to do when we have a patient who is 8 years old is just take a panoramic x-ray to screen for congenitally missing teeth and look for teeth that are becoming impacted. Okay, so here we have a missing lower second bicuspid and some other teeth that we need to account for here. Missing permanent incisors or canines. It's difficult to see in this image. Okay, but the other thing that we can see on this image is impaction happening. When you can see that your upper canines are overlapping the root of your upper lateral incisors, that is a sign that that tooth is becoming impacted. And we're going to need to do something in phase 1 in order to get that canine to erupt properly so that we don't end up with that canine completely impacted and have to go up there and do surgery to retrieve that tooth or possibly even extract it. Okay, so early screening, just to make sure that we're not dealing with any congenitally missing teeth. Normally lower bicuspids and upper lateral incisors are the most commonly missing teeth. So we're going to screen for that because we need to start making plans for that if that is the case. And we're screening for teeth that may be poorly positioned and, you know, are beginning to become impacted. Sometimes we find supernumerary teeth that are going to change the eruption of the permanent teeth that need to be removed so they can erupt properly. So that's one thing we do is we screen. Okay. Then we look in the transverse dimension for crossbites. Okay. We look both for anterior and posterior crossbites. The one that's really significant, I always like fixing the crossbites as early as possible. But the one that's really significant is crossbites that have functional shifts. Crossbites that cause the patient to move their mandible to the left or to the right in order to get their teeth together. It's kind of like what we talked about earlier with the pseudo class 3 cases where the patient will move their jaw forward to avoid a collision of the front teeth. Here, it looks like a unilateral crossbite. It looks like there's only crossbite on the right side and that the left side is pretty okay. But in reality, if we look at the upper midline compared to the lower midline, we can get a sense, and if we saw this patient's entire face, we might even see that their chin looks like it shifted off to their right side. But this patient is shifting their mandible over to their right in order to avoid an edge-to-edge collision on the back teeth. It's uncomfortable to bite on the cusp tips of the back teeth. And so as these teeth are erupting, the patient is moving their jaw to one side or the other to find a comfortable place where all the teeth fit together. Okay? And what we don't like about that is as this patient grows with this bite, their bones do not grow equally on both sides. They end up growing into a more asymmetrical position in their skeleton because of this functional crossbite. So fixing crossbites, whether they're unilateral or bilateral, most of them are bilateral. They just look unilateral like this one. As soon as we can get in and take impressions on these kids or scans, you know, sometimes 6 years old, we can get in and do that. We want to start treatment and get the upper expanded, true expansion, not just what we were talking about a minute ago where we were talking about arch development, okay? We need true expansion to get the maxilla to be wide enough to fit over the mandible, okay? We can have TMJ problems due to asymmetry and asymmetrical facial growth. They don't look as good, okay? After we expand, we're going to touch just briefly on retaining that retention. And by getting rid of this functional shift, we can avoid bad damage to the incisal edges of the anterior teeth and them wearing irregularly and unequal wearing of the buccal lingual cusps of the molars. Okay, so we can avoid some problems by treating those as early as possible. So this appliance right here is called a rapid palatal expander. This is a bonded rapid palatal expander. Okay, we really like these in progressive orthodontic seminars because it opens the occlusion. Okay, these acrylic pads back here open the occlusion so that if there's a functional shift of the jaw's no longer locked into that occlusion. The jaw can shift back into a better position as we do some straightening. Okay, so it uncouples, it unlocks that shifted occlusion as we expand. It also does a great job of grabbing all of these teeth and holding them so that as we turn this crank right here and these screws start to widen the distance between the two sides, these teeth don't just tip to the buccal. They have to move bodily because they're held in this acrylic, which in these young patients will cause this mid-palatal suture, which hasn't completely closed yet. It doesn't happen until they're teenagers. It allows that to open, and now we can actually move the left and right sides of the maxilla away from each other. And then this area in between will fill in with new bone, and we'll get true bony expansion of the maxilla. You can see here that at the same time, while the expansion is being done, we're using braces to align the front teeth. Even though we're still in mixed dentition, we're aligning the 4 permanent incisors to get them out of that crossbite in the back, in the front. And as the bite is opened up because of the acrylic pads, it's a great time to fix that crossbite. Okay, so we're not going to go into everything about expansion. I'm just touching on these things right now. You'll learn all about these when you take the courses, the traditional orthodontic seminar series. And but this is exciting stuff. This changes kids' lives right here to catch this early and fix that for them. Okay, after that correction, so you can see here the correction has been done. Front teeth have been aligned. The posterior occlusion is that crossbite has been fixed. The transverse dimension is nice. We're going to hold that with a transpalatal arch, or a TPA. We're going to hold that until they lose all their baby teeth and get their adult teeth in. So several years of retention. And that way, that mid-palatal suture fills in with new bone, and that becomes a very permanent position for that patient. It's a long-term, lifelong correction. This type of expansion, we don't do this with aligners. Okay, so if we see this problem right here, true full posterior crossbites, either one side, the whole entire side, or both sides, the whole entire side, that's not something we throw aligners in and try to fix. Okay, because those are only 2 millimeters per side. These will need, 8, 10, 12, 14 millimeters of expansion. You're not going to get that out of aligners. Okay, let's look briefly at deep bite. Okay, call it traumatic. It's traumatic because it's either, I like these pictures because you have a big diastema in the front teeth, so you can really see how deep the bite is of those lower incisors. Here you're literally hitting that incisive papilla. And sometimes these patients will come in with pain because they literally are biting on that incisive papilla, and that papilla but behind their upper incisors is all inflamed and swollen. And so other times their front teeth will hurt because they're hitting, the lower incisors are hitting the back of the upper incisors so hard that they're not only wearing the enamel down on their lower front teeth at a really early age, but they also hurt. Okay, their teeth will hurt. So if we recognize a deep bite like this, it's time to get started with ortho. Either refer it out or do it in your practice. Get the training and do it in your practice. Usually we see a deep curve of SPE in the lower arch. Okay, so the curve of SPE is this, hang on. Okay, it's this curve from the back teeth to the front teeth. Okay, so the deep curve of SPE, we'll usually see crowding because those lower teeth are all kind of pushed back. So we'll see crowding in the lower anterior. And if we can treat this in the early mixed dentition, the phase 1, it'll reduce the time of treatment in phase 2 and usually be a better full correction of that bite. Because again, they're growing. We have a lot of control over the bones and the teeth positions as they're growing. So what do we do with these deep bites when we see them? Typically, we treat with braces and we use what's called a utility arch. Okay, here are some examples of utility arches. Okay, we use a wire that when it's not attached to these teeth, the wire wants to be up here. And we have to pull that wire down into the brackets. And we put the brackets close to the incisal edges Okay, so as the patient wears this, the wire wants to be up here. It's going to literally intrude those upper incisors. Okay, so here you can see utility arch in the upper and lower that is intruding the incisors away from each other. Okay, sometimes we call these 2x4 appliances because we have 2 bands on the back teeth and we have 4 brackets on the permanent incisors. And we can fix other things like the alignment, close the diastema, stuff like that. We can do a lot of things with these utility arches, why we call them a utility arch. Okay. Deep bites are better treated with braces. Aligners are not a good choice for treating deep bites. Okay. One of the things that I like to use are these things called lingual bite ramps. Some people call them bite turbos. I've even put these on patients that didn't really need anything besides the deep bite fixed, and it was a early 8-year-old patient who still has mixed dentition, and all I did, the patient came in because their lower teeth were hurting so bad and the enamel was getting worn down, and just to get the patient out of pain, I put these permanent, well, not permanent, but I bonded on these composite bite ramps, and the patient left with a bite. This is an adult right here. This isn't mixed dentition, but you get the idea. The patient left, hitting these bite ramps in the front and a posterior open occlusion. And that got them out of pain because you can't squeeze with your masseter and fire those masseter muscles when you're only hitting your front teeth. It's like giving them a permanent NTI splint. Okay. And so the pain went away because the patient couldn't fire those masseter muscles. And then the patient didn't come back for a while. And when the patient finally came back, these posterior teeth, the primary dentition had erupted passively on its own. And so I had an anterior bite that was no longer deep and a posterior occlusion that had erupted into occlusion. And so I didn't even do any ortho on this patient. I just got them out of pain one day, and then they disappeared. And when they came back, the deep bite was fixed. Okay, generally I try to control more, and we put braces on or do, have more control than just throw these on and let them go. But lingual bite ramps can really help get rid of deep bites on these growing patients. Sometimes all they need is to have their teeth aligned. Sometimes there's just a bunch of crowding in the lower arch. And as we align the crowding, the lower teeth are going to procline or move forward. And as they move forward, the bite is going to open up. Okay, so sometimes they just need early alignment. Sometimes they need some utility arches. Sometimes I like to incorporate these lingual bite ramps as well. And there's a lot more to talk about in that. Like we need to diagnose, do they have a gummy smile? And, how we would not want to move their teeth and intrude them to the point where we don't see their upper incisors when they're talking, because then that doesn't look good. So there's a lot more to consider. But this is one of the things that we look for in mixed dentition, and that I would refer or get started on treatment if I saw, was these deep bites. Okay, so here's one that's been treated with a utility arch. Still a little bit deep, but a huge improvement over the original bite. Also was able to close up that diastema. I like to retain these. Usually I use a Holly retainer while I'm waiting for the adult teeth to come in. And I ask for an anterior bite plane. So as the patient wears this, their lower teeth are hitting, it's kind of like those lingual bite ramps. Their lower teeth are hitting on this acrylic right here. And so essentially the back teeth are not touching while they're wearing this retainer. And that allows more passive eruption of those back teeth so that the bite will get less deep as we're in retention. Okay. Lots of crowding. Okay, we call this an arch length deficiency. We don't have a long enough arch in order to get all these big teeth in there. Okay, so the kinds of things that we do, one, we can develop wider arch forms. So this is kind of like what we talked about earlier, using aligners or wide arch wires to just develop a narrow arch form into a more wide arch form and give some room for teeth. Whenever we move the back teeth out, it makes the circle bigger, the arch form bigger, so there's more space. Okay? So we're not talking here about the kind of expansion where we have cranks and screws. We're just talking about developing the dental alveolar arch form to be a little bit wider. Okay? The other thing that we'll look at in a second is using a lower lingual arch. Okay, that would be bands on the lower sixes. I have a picture of this coming up. And a little wire to maintain that position of those lower molars because of the transverse dimension of this lower lingual arch. It makes these molars not be able to move forward because they would have to move into a narrower part of the arch and they're fixed in their transverse dimension. Okay, and so when these baby teeth come out, these primary molars, these E's, we call them, there's more space than what the permanent bicuspid needs. And by holding these molars into a more distal position, we're buying room in this arch for the teeth to fit. Okay, so here's an example of crowding in mixed dentition. You can see that there's upper crowding, maybe 3 to 4 millimeters already. We haven't even tried to get the adult teeth in. And there's lower anterior crowding. So when you try to picture the canines and the bicuspids and everything coming in, it's going to be crowded. Here's this patient's panoramic x-ray. And you can see there's already some overlap of the canine to the root of the lateral on both sides. So we're already starting to see signs of the upper canines impacting. That tells me that we need more room up there. Okay, and you can see that there's just a lot of teeth to come in for the space that we have available. Okay, so taking this patient early and expanding those, if you look back here at the previous slide, you can see that these upper, even though they're primary teeth, they look like they're tipped into the lingual. And so tipping those out so that they become more upright and widening that arch form is going to give more room for those canines to come down. And it's going to create more space to align the crowding in the front. Not every child who has some crowding in the front needs to start braces right away. Okay, but if they have lots of crowding, it's a good idea, especially to avoid impacting the canines. And if we can develop a nice, broad, rounded out arch form early, that will help the patient develop and have a nice, broad smile and good function. Okay, so this patient was treated with aligners in mixed dentition. And you can see an overlay here. So you can see the blue is where the positions of the teeth started. And the white would be the proposed final position of those teeth. So about 2 millimeters per side of expansion in the upper and lower. And let's see how that treated out. Okay, you can see the dimension here from start to finish. And you can just see that overall there's a nice broad arch form developed compared to this more tapered arch form. And it made room to fix the crowding. Okay, see how this looks wider in the lower compared to the start? And now we've got some room to align that crowding. Okay, so we do use aligners on young patients who are mixed dentition, or sometimes we'll put braces on if we have other things we're trying to fix, like a deep bite, and we'll use an expanded wire to give a more round arch form, a little bit more developed wide arch form. This is the lower lingual arch. Okay, so these get cemented in the mouth when we can tell that there's going to be crowding problems. We cement these before the lower E's or the lower second primary molars are lost. Okay, so we make it so that these lower first molars, the permanent first molars or the sixes, cannot drift mesial. Normally they would drift mesial when these lower E's are exfoliated. They would drift into what we call the E space. All right, but if we place this lower lingual arch, it holds them in this posterior position. And now we buy extra room because those bicuspids aren't as large for the crowding to fit in. Okay, and we keep that there until those permanent bicuspids have erupted. You can see how much smaller those are than the size of the primary molars. Okay, so this is another way that we get room in the arch to fit the teeth, is a lower lingual arch. Don't have time to go into a lengthy discussion about the lots of class 2 or lots of class 3. Just know that when you see lots of class 2, you know, they're very retrognathic. Looks like their mandible is too far back and they need surgery to move it forward. Or their mandible is too far forward and they need it to move back. We see this at a young age. This patient needs orthopedic treatment. It's more than just moving the teeth. Okay, we need to move bones. We need to help this patient through their growth spurt to develop a better facial balance. Okay, and we can do that, for example, in class 3 cases by using a reverse headgear. The patient wears it at night, and we're able to actually pull the maxilla forward to keep up with the growth of the mandible. Okay, there's a lot more that goes into this. This is very simplified, but there are some significant things that we can do if we recognize these problems early and are able to use the growth of the patient to help improve the overall result of the facial balance. With class 2, we have cervical headgear, so headgear that would pull the upper, it doesn't really pull the upper back, it more just restrains its growth. But other things that we can do are functional appliances. Okay? Maybe you've heard of the MARA, the Mandibular Anterior Repositioning Appliance, or the Herbst appliance, which is pictured here, or the twin block appliance. There's all kinds of functional appliances out there. Functional appliances means that we're putting something in the patient's mouth that's causing them to posture or hold their mandible in a more forward position, almost edge to edge. And by doing that, it not only moves the teeth, so it's dental alveolar movement, it moves the teeth further forward, but as the patient grows, it actually changes and reshapes the head of the condyle, the shape of the TMJ, and it allows the patient to have a little bit more forward position. We can't make the mandible grow bigger, but we can help to hold it in a more forward position as the patient grows. What I have pictured here in these aligners is something that Invisalign offers. Okay, they're called their Mandibular Advancement feature, and it's in their teen aligners. And their wings kind of works like the twin block appliance or the MARA appliance. It makes it so that as the patient goes to bite together, these wings are going to collide with each other. And so the patient really has no choice except to move their mandible forward so that they can get their teeth together, so that these wings will slide together and the jaw has to be in a more forward position. And as the patient wears these aligners for 12 months, 15 months, it changes the class 2 into a more class 1 occlusion. And there's lots of different appliances out there, but we have to pull out some big guns when we have lots of class 2 or lots of class 3, and we need orthopedic treatment. We need to change the way the bones are growing. I love that topic. I wish we had more time to go into it. Space maintenance, okay? If we see that a child, we should know, we were taught in dental school, this is one thing they did teach us, right? If a patient loses primary molars, especially lower second primary molars or primary canines, it's kind of a big deal. If we don't put retention in there, space maintenance, we can end up with some real orthodontic problems. And if we see this problem, if we see that a patient didn't have space maintenance, and they're, especially in the lower arch, the lower molars have drifted forward and eaten up that space where there used to be a primary molar right here. And if that space has gotten eaten up, we need to get in early and figure out how we're going to treat this case. Are we going to do serial extractions and plan on extracting permanent teeth? Are we going to try to distalize things? We have to decide, for each patient what the best solution is. If there's no room for these lower canines to come in because those were lost early. If there was no space maintenance and primary teeth were lost early, we really want to get in and figure out what we're going to do. Sometimes we'll do nothing. Sometimes we'll wait until full eruption knowing that we're going to pull teeth anyway. But other times we want to get in and fix that. So that's another thing to be on the watch for and either refer or take records in your practice when you see that. I wish we could talk all day about mixed dentition. I love it, but I'm going to leave it with this. Our treatment goals in mixed dentition is to try to establish something that allows us to treat non-extraction once we're in permanent dentition. If I can set the patient up for success, beautiful function, beautiful smile without having to pull their teeth in their adult dentition, I would like to try to do that. If we get in early while they're in mixed dentition, we have a better chance of a full orthopedic correction. We make their face look better. Okay? It's not just moving teeth, we're changing the way the bones are developing and growing. We're moving bones. Sometimes we can't get a full correction in phase 2 if we don't do phase 1. Okay, so by doing phase 1, we're able to get a full correction sometimes of the malocclusion in phase 2. And then the earlier we get in and get teeth in the right positions, just the better overall retention we have, because the bone and teeth have been in that position longer. I love phase 2. I love our phase 1 mixed dentition treatment plan. So hopefully you'll join us in a comprehensive series and learn all about it. Okay, I am already at an hour and 10 minutes, so I'm going to have to move a little quickly through these next 2 topics. But let's touch on open bites, okay, both in growing patients and in non-growing patients. Okay, if I see an open bite, okay, so here the patient is biting on their back teeth, and they're completely open in the front, okay? If I see that in a growing patient, the sooner I see this and recognize it and can do something, this patient can correct that problem really fast, and it can be permanent. It's because they have either a tongue thrust, okay, they've developed a habit of thrusting their tongue when they swallow. They could have also a mouth breathing problem. They could have a lip problem where they're sucking on their lower lip and pulling it up into their overjet, or they could have a thumb sucking habit, okay? But they have a habit because teeth want to erupt until they hit something. So the fact that they're not erupting into full occlusion tells us that something is in the way and not allowing that. It's usually the tongue. It can also be the thumb. It can also be the lip, okay? So what I'm looking for is, if they have an open bite, I'm going to do something, okay? First, I want to make sure that they can breathe through their nose, because if they can't breathe through their nose, they're going to have a hard time ever getting their bite closed. So if I have the patient close their lips and I ask them to breathe through their nose and I hear a real constricted airway, I give a lot of referrals, and I have a good relationship with an ENT who can, I don't know what they're going to do. Sometimes they need to take out tonsils, adenoids. Sometimes they just need to give them some drugs to get rid of the inflammation in their nose. But I need that patient to be able to breathe through their nose so that they can have their lips closed. Okay, if they can't breathe through their nose, I'm not going to be able to help them get their lips closed. If they have a tongue thrust, I like to put lingual cleats. I'll show you a picture of that in just a minute. I like to put cleats. That's all I'll do. No braces. We just put cleats on the lingual of the upper incisors and tell them to not touch it with their tongue. And the teeth will erupt. They will come down as long as the tongue is out of the way. I also have a good relationship with a myofunctional therapist, one who feels passionately about orthodontics and myofunctional therapy. And I'll refer these patients to myofunctional therapists as part of their treatment so that they can learn how to swallow properly and learn how to use their mouth and their muscles in their mouth properly so that they develop properly. Okay, lip habits. Those usually go away just as we align the teeth. Sometimes I'll put cleats on. There are such things as these lip bumpers to hold the lip out of the way. I don't tend to use those very often. I just find that just getting started with aligning the teeth and maybe putting some cleats on the back of the upper incisors can keep that lip out of that overjet. I really like these bluegrass appliances if they have thumb habits. Okay, if they're at an age, if they don't want to quit sucking their thumb, they're just going to keep doing it. But if they're at an age where they want to stop sucking their thumb, they find that this little roller right here, which was discovered with horses, putting a little brass roller on the horse's bit so that they found that the horse would calm themselves down by playing with it. So somebody tried that with a patient, and the patients find that if this little nylon roller here can roll freely, they'll play with it with their tongue. They'll sit and roll it with their tongue, and that's more fun than sticking their thumb in there. And so once the thumb goes away, then the teeth will start to move. Okay, so here you can see that there's a posterior crossbite and an open bite. And so we're treating with both a rapid palatal expander and a bluegrass roller. Again, I wish we could talk for an hour about these open bite cases on young people. Okay, here's a tongue thrust. You can see there's a transverse problem. This is really common whenever we have anterior open bite. There's often a deficiency in the back, and we need to do some expansion as well as doing something to get rid of the habit. So this is an example of a tongue rake. Okay, here it is right here. Place in the mouth to hold the tongue back. So when the patient bites together and swallows, their tongue can't go into that space, and the teeth will close as long as the tongue isn't there. Now, on adult patients that don't have eruption potential, if we just get the tongue out of there, they don't necessarily just close on their own. But on young patients who have eruption potential, their teeth want to erupt, We just have to get rid of whatever is in the way, and the teeth will start to erupt on their own. I love these tongue tamers or lingual cleats. Just putting those on the back of the upper incisors when you see a patient that has open bite, they'll come back. You did nothing else. You just put cleats on there. They come back in a month or two, and all of a sudden their bite looks better and will eventually close on their own. So we can really make a difference when we see open bites on young patients. Okay, can also treat with aligners. So here's a mixed dentition. You can see that there's primary teeth back here. And we have permanent upper and lower incisors on an 11-year-old. Oops, let me go back and show you the video. Hang on. All right, here's the video. Hopefully you can see the video play. You're going to see the clean check from different angles here of extruding the front teeth with aligners. Now, extrusion is really hard to do with aligners on non-growing patients, okay? But on patients whose teeth want to erupt, they're young patients, then their teeth have eruption potential. And we put these aligners in with these little attachments on the front made out of composite to give the aligner something to push against. The extrusion can be predictable. And we can actually close a bite that was open by using aligners. So there's lots of different ways to close anterior bites on young growing patients. And it's easy to do as long as we can get rid of whatever is there, the thumb or the tongue or the lip that's keeping the teeth from coming together. One more view here, and then we'll show you the result of that case. Okay, so here's how that case treated out. About 10 to 12 months of treatment. We're still in mixed dentition, but now we have a closed anterior bite. Okay, just some ideas we're throwing out there, definitely not comprehensive. Let's talk about in non-growing patients. Now, it's a little bit more challenging to treat an open bite because, one, they don't have eruption potential. Their front teeth aren't trying to erupt anymore. They've been stuck in that open position for a long time. And they've really established those habits. You know, so if they have a tongue thrust, they really have that established. Okay, I still like to use myofunctional therapists even on adults with open bites. And I still like to make sure that they have a nasal airway so they can breathe once we get them to close those front teeth and keep their lips sealed. Adult patients who have open bites, sometimes it's so bad they require surgery. Okay, so we're not talking about surgical cases here. We're talking about cases where there's a moderate open bite in the front. Okay, and aligners are the better appliance for treating open bites in adults compared to braces, because braces tend to open the bite and aligners tend to deepen bites because they tend to intrude the back teeth as the patients bite on the occlusal surfaces of the aligners. Okay, and by the time they're adults, we have over-eruption of the back teeth. And so what we want to do is we want to intrude their back teeth, and the aligners do a good job of that compared to braces. Unless we're using TADs or skeletal anchorage with the braces to help intrude the back teeth. But the braces alone don't do a good job of that. And a lot of times we also have some posterior crossbite or deficiency on the adult that needs some help from the aligner to push those teeth out. But like I said, and it's not every case. There are definitely cases that require surgery to fix. So we're talking about mild to moderate open bite cases. Something like this young man here who has his teeth closed in the back and he's completely open in the front. You know, when he bites a sandwich, he leaves the lettuce and the meat behind. Okay, so you can see his posterior occlusion and he's open in the front. And of course, he's got a tongue thrust. He likes to stick his tongue in there. It looks like he's already had braces because his teeth are straight. He just has an open bite. He can't, bite a sandwich or pizza. And you can see in the back that his posterior teeth are over-erupted. Okay, so the way to treat this patient is to actually try to intrude the back teeth. So we're going to leave the front teeth where they are, and if we can intrude the back teeth away from each other, so we put features into the aligners and movements into the aligners that are pushing those teeth away from each other. and we're encouraging the patient to bite and clench on their aligners to push those teeth away from each other. And if we can push those teeth away from each other, then the patient will be able to rotate their jaw up and close the bite. Okay, so that's what we're trying to do with adults. And we find that aligners work really well if the patients are really good at wearing them. Okay, so here's how it worked out for this patient. Nice closed bite. And since there wasn't a lot of alignment to do, this was done, without having to move a lot of the teeth, just simply about 12 months of wearing the aligners and pushing those back teeth away from each other. Okay, bite got closed. You can see that the posterior teeth are now more in the overall plane of occlusion than they were originally. So we did not extrude these teeth to close the bite. We intruded the back teeth, which is good because if you go back and look at this patient at the start, he shows a good amount of his upper incisors. We don't need to see more of his upper incisors. And if the patient already had a gummy smile, we really wouldn't want to extrude those teeth down and make their smile more gummy. So this is an example of what we do with a setup with aligners on adults, okay? Is we want to finish, we put features in like these attachments that go on the occlusal surfaces of the back teeth. So they're just like empty bumps in the aligners. We don't fill those with composite. And so when the patient bites and squeezes, there's these bumps in there that are kind of pushing the teeth away from each other. And then we're having the aligners actively move the teeth away. So our final setup is going to show posterior open bite. And we might extrude depending on what the position of their incisors are aesthetically. Sometimes on adults, we can add a little bit of extrusion to help close the bite. But what we're looking for in the final position of the aligners is posterior open bite. Because as the patient's teeth get moved away from each other in the back, they're able to close their teeth in the front. Okay? And it's pretty predictable with aligners if the patient is willing to wear them and if they clench their teeth together in the back. Okay, I'm not going to spend any more time on that. I'm already going over my time here. So let's talk about this last topic. Just briefly touch on some high or impacted canines. Sometimes all we have to do is extract primary canines and do some alignment, create some space, maybe some expansion, maybe some distalization. If the upper posterior teeth drifted forward a little bit, maybe pushing them back a little bit. Okay, just make room and wait for the canine to erupt. Now, braces are fabulous at pulling canines down. It's really easy to put a bracket on that and then have the wire pull that tooth down. But with aligners, it's a lot more challenging to pull that tooth down. So if I'm going to do aligners on a patient that is, young, growing, their teeth are supposed to be coming in, but they're high, I just want to go in and get rid of that primary canine and just let that tooth erupt, because it's going to be a lot easier to start my aligner case and if I don't have to pull this tooth down with aligners. Braces, no problem. We'll put braces on and pull that down, no problem. But with aligners, I like to just wait. Just wait a few more months until that tooth has come down, and now I don't have to try to manage that with the aligner. Okay, so just creating space, extracting primary canines early, sometimes creating space by expanding or distalizing, wait for that canine to come down. Here's an example. Okay, the canine came down on its own. Now is a nice time to start the aligner case, and you can bring it down the rest of the way and fix the case. Incidentally, in this case, there was a lower left canine that actually needed surgical exposure and to be brought in surgically. Okay, so aligners versus braces bringing down canines. If we have a young patient whose canine wants to erupt anyway, we can create in the aligner, Invisalign and some other companies provide basically like a pontic space or an eruption bubble, we call it. Just a space so nothing's touching the canine so that the canine can just erupt. So as long as it's not having a collision on the mesial or the distal and the aligner's not actually touching it up here, we've just created a space in the aligner. Oftentimes that canine can just erupt on down in. But a lot of times the canine is positioned where it's kind of flared out to the buccal. And so it's a lot more difficult to just create a space. And if we're just going to go straight to aligners, we can end up having to do this where we cut the aligner so that we can place a button on the canine and we have to modify the lower aligner so that we can place buttons. And then we end up having to have the patient wear elastics to help us pull that canine down into place. That's a lot more work than using braces. With the braces, we just put the braces on, we put a bracket up on that tooth, and when we put the nickel titanium wire, which is very flexible and wants to return to its original shape, when we put it into these brackets and we get wire deflection up to that canine, that wire wants to get straight. And so it's going to pull those teeth down because we have a handle, we have a bracket on that tooth, and it just pulls that down. The wire wants to go straight, and so it brings that canine with it. Okay. So in my experience, I either like waiting, making the room and waiting for the canine to come in before I start the aligners, because I don't really enjoy doing this, or do braces. Okay. And sometimes what it is, hey, I'm going to put braces on for, 3 or 4 months, and then we're going to take the braces off because you really want aligners. We can go switch over to aligners. Or this case would just be better treated with braces, and they're happy to have braces. Let's do the whole thing in braces. Okay. I really like providing both in my practice. There are things braces can do way better than aligners, and there's things that aligners can do better than braces. And in our aligner course, we go over those strengths and weaknesses of each of the appliances. Okay. Braces are way better at extruding teeth. Braces are way better at tipping and moving roots. Braces are way better at torquing teeth, torquing the roots of the anterior teeth so they have a better final inclination. They're way better at fixing rotations. Aligners are way better at expanding or developing an arch form. Aligners are better at intruding the back teeth so that we can close an open bite. Aligners can be better because the patient's more willing to fix their teeth with aligners. So they have strengths and weaknesses. And I really like having the education and know how to do both braces and aligners so I can provide those options for my patients. And we can talk about what would work best for them, which one they would prefer, and do what is going to work for them. So I would highly encourage you, if you know how to do braces, but you don't really know how to do aligners, take the aligner course. If you do some aligners and you've never done braces, take the braces course. The more knowledge you have, the more services you can provide, the more cases you can treat, the fewer referrals you have to give. When you take the full series, you'll even learn how to do surgical exposure and retrieval of impacted canines. Okay, where we expose the canine and we bond a little eyelid onto it, and we use a piggyback wire. So we have 2 wires in here, and we're deflecting one of the wires towards the tooth and slowly pulling that canine into the arch. And these are really fun cases, because you just, again, you change somebody's life by saving a canine that otherwise would have been extracted and they would have had to have an implant, or they would have had asymmetry in their mouth. Ortho is fun. I love it. I love what we can do for our patients. So we're coming up on the end of our time. If you'll go ahead and answer this question for me, I'll give you about 10 or 15 seconds. And then we'll talk just very briefly about what these different courses that Progressive Orthodontic Seminars has to offer that I've touched briefly on. Awesome. Well, most of you enjoy thinking about, talking about, learning about ortho. I love it. I just think it is one of the coolest things. I love learning from other general dentists who are doing it in their practice. And that's what I think is great about Progressive Orthodontic Seminars. You will learn everything that you would have learned if you'd have gone to ortho school. But you don't have to limit your practice to just orthodontics. Okay, so Progressive Orthodontic Seminars is the world's #1 orthodontic education and mentoring system. Okay, it is comprehensive. You learn everything about ortho. We're not just going to teach you the bare minimum. You learn everything there is to know about ortho, up to full surgical cases. It elevates your practice, especially in the eyes of your local specialist. Maybe not your local orthodontist, but your local oral surgeon, endodontist, periodontist, pediatric dentist. When they see the kind of work coming out of your practice where you're treating the whole mouth, I got more referrals from specialists, and they sent patients who had complex cases who needed a lot of dentistry, and they came in already trusting me because they referred to me by a specialist, already knowing their case was difficult and already knowing that it was going to be expensive. And I didn't have to convince them of all that. I just helped them put together a plan. And I love that kind of work. Okay. Orthodontic or progressive orthodontic seminars provides a really high level of support. We're not just going to teach you and turn you loose. Okay. You have access to consulting and mentoring so that you can confidently start cases in your practice. It's really difficult to go in and confidently talk to your patient about the orthodontic services you provide when you don't have a lot of experience. But if you know that you're going to be taking the records of the patient and sending them to a mentor, and the mentor is going to help you work up a plan, help you through that plan, help you address problems as they arise, answer questions, like we're going to hold your hand through these cases, then you can confidently say to your patients, hey, I do orthodontics in my practice, and I can treat your case. And we talk a lot about this in our courses, but you can confidently start treating patients even before you've completed a bunch of cases, because you're going to have somebody literally there helping you through every step of the way. Also, you get to earn money while you're learning, because as you start these cases, they pay money, $5,000, $6,000 a case. So you get to pay for your education and actually increase your revenue as you're learning how to do ortho. Okay. Progressive Orthodontic Seminars has a free lifetime retake policy. So there's 4 different formats. We have full in-person. Now that COVID is backing off, we have full in-person courses, which is my preferred way to learn. I just have to put aside everything, no distractions, sit down in a classroom and learn from the instructor. That's my preferred way to learn. But we also have internet-assisted training. It's kind of a hybrid where you come for like 4 weekends to learn the real hands-on stuff, the stuff that you just need to be with an instructor. And then the rest of it is done on the internet. We have a virtual classroom, which is webinars that are taught in combination with self-study. And then we have full self-study, full self-paced, where all of the content is available for you to learn at your own pace. And you still have a mentor consultant to help answer questions and help you through stuff as you're learning. So there's different formats for learning. No matter what format you choose, for the rest of your life, any course you've paid for, you can always go retake it in any one of these formats. So if you took it as a self-paced course and all of a sudden it's being offered right down the street from you in person, you can go show up for free and sit through the whole weekend and the whole entire 12 series if you paid for it all, and retake the whole thing in person. Go to smilestream.com. Check out the free software that we use in doing our orthodontic cases and in doing our consulting and mentoring. There's a wealth of information there that's free. And that's where you can learn more about these seminars, is smilestream.com. And it's both the traditional ortho series and the aligner series. I love the classroom setting for learning. Okay, so the traditional orthodontic series is 12 4-day seminars in person. Okay, or you can do the internet-assisted training one, which is 4 3-day seminars with self-study, or the virtual classroom, which is 30 3-hour webinars plus some self-study, or the fully self-paced one, where there's videos and online content, and you go through it at your own pace with instructor support when you need it. I highly recommend this course. Okay, took me 2 years to get through, completely changed my career. Completely changed my practice. I loved it. This is the shorter course. It's an aligner course. We do teach you how to put brackets and braces on, just in those cases where we're like, hey, 3 or 4 months of braces would really help this be a better aligner case. There's just too many rotations or too many tip roots. And if the patient would allow us to put braces on for 4 or 5 months, we can convert this into a good aligner case. So it allows us to treat more cases with aligners if you know how to put some brackets on. So we're not teaching you in this course how to do mixed dentition. We're not teaching you how to do full braces, but we are teaching you enough braces so that you can bail yourself out if you get in trouble with the aligners, or you can turn a difficult case into a better aligner case. Okay, this one is 4 3-day weekends in person. That's my preferred way to do it. Or there's also the internet-assisted training one, or the webinars, or the fully self-paced. And again, you take one, you can always retake the other one for free anytime. We have classes starting all over the place. There's free 1 day. If you enjoyed this 1.5 hours, I recommend that you go to a free full day. and they're all over the country. There's a lot of them opening up. You can contact Progressive Orthodontic Seminars and find out where the dates and locations are. That's what I did first. I went to a free one-day introduction, and after the end of that one day, I was like, my mind is blown. I just have learned so much and just found that I really love this. And so I signed up for the whole 12 seminar series. But if you want to get a little bit more, go to one of the free full-day seminars, and you'll love it. I'm going to leave this up for just a minute. I'm going to finish on this slide. There's some smilestream.com. Okay, there's a phone number here. There's an email address. Okay. I encourage you to learn more ortho. And hopefully those of you who are already doing a lot of ortho have learned something, have heard something that you enjoyed. I really enjoyed my time with you guys tonight. I appreciate you being here. And I will stay on for a few minutes here and look through questions and see if there's any questions that I can answer. But those of you who need to go, thank you so much for being with us, for being with me. I really enjoyed our time together. All right, I'm going to go over here and look through some questions. It looks like Iveta has been typing some things to all of you about the free one-day seminars over here. Hopefully you saw that. As far as getting the CEs, those will be sent out by Progressive Orthodontic Seminars. If you don't receive that in a week, if you want to get it sooner, you can email them and they'll email that back to you sooner. Otherwise, it'll probably come in a week or so. If you don't get it, you can email info@posortho.net right here and make sure that that gets emailed to you. Other questions? Somebody said, I already have experience with providing comprehensive fixed appliances. I want to get experience with aligners. You do not need to do the full aligner series. I do recommend that you take the whole thing. The first course will be a little bit of review, but we go through some basic orthodontic principles, but geared towards aligners. So it'll get you thinking towards the aligner way of looking at cases. So I would recommend that you do all of it, but for sure, you're at least going to want to do the last 3 seminars. The first seminar can be a bit of a repeat for those who already got a pretty decent ortho education. How do you stop tongue thrust in the adult? Well, really in the adult patient, you have to close the open bite. Okay, as long as the teeth are apart, whenever the patient goes to swallow, they have to put their tongue there in order to swallow and not have food or liquid come out the front. Okay. So with braces, we put the braces on, we put elastics between the upper and lower teeth, and we try to pull those front teeth together. We'll put lingual cleats, those little tongue tamers or sharp cleats on the back of their incisors or wherever their tongue thrust is to really encourage them to not stick their tongue there. And I also send them to a myofunctional therapist to give them exercises on learning how to use their tongue properly and proper swallowing techniques for their tongue so that they can get their tongue out of there. As long as the tongue is still there, the tongue will overcome your elastics, your braces, which is another reason why aligners can be better for open bites, because not only is it intruding the back teeth, but when the aligners are in the mouth, the tongue doesn't really have any effect on the teeth. So it kind of removes the tongue while we're closing the bite, because if I just have braces on, I can still press pretty hard on my teeth with my tongue, and the tongue muscle is stronger than the forces from the braces. But when the aligners are in, the plastic doesn't really deform if the patient pushes on it with their tongue. So the force of the tongue kind of gets taken out of the equation, which allows the bite to fix better. So I prefer using aligners. There is a specific way that we do it with the aligners. That would take me about an hour to describe. We touched on it briefly, but we got to get rid of the tongue from being in that space. If we intrude posteriors, won't we be starting a TMJ issue, since TMJ will be now further up and back? I've never experienced a patient having TMJ issues from intruding the back teeth. In fact, they usually have open bite patients who don't have good function, They only occlude on their back teeth. They tend to have TMJ problems. They don't have anterior guidance. And so as we intrude the back teeth, it's only dental alveolar movement. And as we intrude the back teeth and allow them, the patient doesn't really change their vertical dimension. You know, if we were to take a lateral ceph and look at it at the start of treatment and at the end of treatment several years later, they're going to have the same vertical dimension, but we've changed the way that the teeth fit together in their mouth. But all of my patients who have anterior open bite, who have had TMJ problems because of that lack of anterior guidance, their TMJ symptoms greatly improved after we got them anterior guidance on their canines and their incisors. So I've only found that TMJ ever got better as we close those anterior open bites by intruding the back teeth. Are the aligners retentive with the primary teeth? It can be challenging to get the aligners to fit well with primary teeth because those primary teeth don't have a lot of undercuts. They're pretty tapered. And so when we do aligners with primary teeth, I tend to put a lot more horizontal engagers on those primary teeth. At least the first and second primary molars, just kind of in the middle of the aligner, it gives some snap, some retention to those aligners. That's a great question. Do these open bite appliances work on adults? Yeah, I think I've answered that question. We don't use tongue rakes. I don't use tongue rakes. I do use the lingual cleats on adults if I'm doing braces. Those bluegrass appliances, you know, usually people are able to get rid of their thumb sucking habit somehow before they reach their 20s. But I have used it successfully on kids that are 17, 18 years old for the tongue thrust. I just find that for adults, if it's not such a severe case that needs surgery, I find that using aligners to treat them works very well and predictably. Lower E-space often allows the molars to come forward into a class 1 occlusion. Is there a risk with lingual arches of keeping patient in class 2 molars? So that's a really good question. If the patient has a lot of dental class 2, we often like the fact that there's E-space because it lets the molars shift into class 1. But other times we can avoid an extraction case because we kept that space. And yes, you'll hold them into a class 2, but there's other ways to fix that. You know, we can distalize in the upper, we can advance the lower bodily, you know, in mass, all of those teeth can be moved forward. We can use functional appliances. There's other ways to fix the dental class 2. But there's a lot of cases where if we didn't put that lower lingual arch and maintain that lower E-space, it would have gone to an extraction case. And so we can take a case that has crowding and end up treating it non-extraction, even though we might have to use some distalization in the upper or a functional appliance to fix the class 2. We didn't have to extract teeth. I was going to say something else about that, but I just forgot what it was. Oh, class 3 cases. If you have a patient that has any kind of class 3 occlusion, even a little bit in mixed dentition, or they have a class 3 tendency, they look a little bit class 3, or you take a lateral ceph and we trace it and we can see that they're class 3, getting that lower lingual arch in there is paramount before they lose those lower E's, because we don't want to allow that lower molar to come forward at all, because that makes them more class 3. So for sure, anytime I have any hint of class 3, that lower lingual arch is going in there. If it's class 1 but crowded, that lower lingual arch is going in there. And if it's class 2, I just have to make a decision based on each individual case. If it's just a little mild class 2, I still like the lower lingual arch if there's a lot of crowding. If it's a lot of class 2, it's kind of case by case for me. Do utility arches work in growing patients, but already with all the permanent teeth? No, if we get to the point where they're still growing, but they have all their permanent teeth, we just go ahead and bond all of their teeth. And the utility arch is really for cases where we just have the upper permanent molars, lower permanent molars, and anterior teeth, and we're skipping the primary teeth. So yeah, we don't use utility arches. We do similar things, but we do it with bonding and bracketing all the teeth. Doc prefers 022 or 025. In progressive orthodontic seminar, or in our appliances, we use 025. We use a 19 by 25, 18 by 25 wire, and brackets that go with that. What makes a profile concave? Is it primary maxilla that makes it? There's a lot of different things that can make a profile concave. It can be retruded teeth, or it can be retruded bones, or it could be both. It could be strong chin buttons. It could be large noses. Whatever's causing it, anytime a patient has concave profile, we tend to not want to retract their teeth. I tend to not extract them, not retract anything. Everything's focusing on moving teeth forward rather than moving them back. Do teeth tip with aligners for expansion? Does the suture actually change with aligners? No, we don't ever try to change the suture with aligners. If we need to change the suture, we use rapid palatal expander, usually the bonded kind, so that the teeth don't tip. With the aligners, we do put extra tip in the root. So we actually, when we're expanding, if we have upper posterior teeth that are already tipped to the lingual, we just go ahead and expand them, because really I do want the crowns to tip buckle, because I want them to kind of upright. But if I have teeth that already are upright in the back and I want to do some expansion, when we apply expansion to the crowns, we actually ask the technicians to add extra expansion to the roots to the buckle in an attempt to overcorrect and not tip the crowns to the buckle. Because we don't really want to tip them and flare the posterior teeth out to the buckle. We would like them to be upright and have their roots under them. So when we do it with aligners, it's 2 millimeters per side, and we do put features into the aligners like extra labial root movement to try to compensate for the fact that the aligners will tend to tip those back teeth. And the last question I see here is, what is IPR? IPR is interproximal reduction. We talk a lot about it in our aligner series, and it's basically just removing a little bit of tooth structure between the contacts of the teeth. But the most we ever do is like 0.25 millimeters per surface. And so it doesn't really damage the teeth. It doesn't damage the teeth if you do it properly. It has no long-term negative effects if it's done properly. And it's a way to create some space to fix some of our problems. If we just send cases to aligner companies, the technicians tend to put too much IPR in the cases. We don't really need to put that much IPR in the cases. But there are cases that the IPR is helpful in getting our desired results. So we do use that. All right, you guys, it has been awesome to be with you. I am going to end here and take my wife out for dinner for our anniversary. So thank you all for being with us. Please get a hold of Progressive Orthodontic Seminars if you would like to learn more. And you all have a good night.